Welcome to On the Edge of Breakthrough, where hope meets innovation in the fight against cancer.
Hi, I'm Dr. Monty Pal. I'm a medical oncologist at City of Hope, and I'm really excited to bring to you On the Edge of Breakthrough, Voices of Cancer Research. We're going to be bringing some of our best researchers to the table to discuss exciting findings from their laboratories, from their research programs, and really get some great perspectives on what their plans are for the future. Welcome back, everyone. I am thrilled today to have one of my dearest friends here on campus, Mustafa Raoof, a tremendous surgeon scientist, here today to discuss some of his amazing breakthroughs in oncology. Mustafa, welcome, my friend.
Thank you. Thanks for the invitation.
Gosh, I don't even know where to start. I mean, you have such an amazing story, but I do want to kind of really dig deep and maybe actually go back to Pakistan. I want to hear about that journey initially that led you towards the field of oncology.
So I grew up in Pakistan, and I grew up in a household where my mother was a physician and my dad was an engineer. So a lot of focus on STEM from the very beginning. Somewhere when I was 12 years old, I decided I wanted to be like my dad, who was actually in the army at that time. And so I decided to join a boarding school. But then in about 10th grade, I realized that I wanted to get out of that boarding school. And the only option that was not available in that boarding school, the boarding school was phenomenal, by the way, it set me up for success throughout my career, was medicine. So I told my parents I'd like to pursue medicine, and they had no choice but to get me out of that boarding school. And that's how I stumbled on being a doctor. But then, as I grew more into the area of learning about medicine from my mom and, kind of looking at her example, I became more serious about it. And when I ended up in medical school, I really loved every minute of it. So, from there on, there's obviously a lot of training that's involved, and we can definitely get into the details of that. But I think that kind of example was set from the household, and then a lot of peers that I interacted with during medical school really pushed me into the world of surgery, and then slowly and gradually from patient experiences, just learning from patients and the areas I like to provide help with, ended up with me being more into surgical oncology.
I know that was a pretty far-reaching question. How'd you go from, Pakistan to oncology, right? But, I want to make sure we don't gloss over one thing, which is that you went to Aga Khan University, which is one of the most challenging universities to get into, right? So you went from making this decision in boarding school to getting in there. I think that really speaks to your drive and your focus. Am I right? I mean, you must have really had to turn it up to high gear to really achieve that.
Yeah, I think so I have, growing up, I was always more focused, and I always kind of had I would make a decision and then pursue it. And so, my mother tells me this now. I don't remember having this conversation, but she told me that if I wouldn't get admitted into the best medical school in Pakistan, I would do something else, that kind of, ride and die personality, I think kind of pushed me to work really hard to get into the medical school that I desired to be in. And, Aga Khan University is kind of an example setting institution of higher education in Pakistan. There's close to 7,000 or 8,000 applications, and to select 70 applicants from that. And there's a very strict process of how people get admitted, and so I was just fortunate, really grateful that they picked me, and really I think that moment was really transformational.
70 out of 7,000, that is just wild. And I'll point out too, I think we have other City of Hope superstars from Aga Khan University. Tanya Siddiqui comes to mind in hematology, who's brilliant, Lancet papers left and right. And really, you're no different. I think every time I look on Medline, you've got another paper that's been published. It's pretty incredible. One of the things I wanted to sort of dive into with you is this surgeon scientist role that you have. And you and I have had a lot of late night conversations around this, right? I've talked to you about, how I find it personally so challenging to balance the clinic with, all the research that I'm doing, then family life and commitments. But of course, you do this in spades. And not only do you actually manage the clinics, you actually have a bustling surgical practice. He's a terrific surgeon, by the way, guys. I have to tell you, I've had so many complex cases that I think only Dr. Raoof would have been able to navigate. But beyond that, in the domain of research, you divide your time between the laboratory, between doing outcomes, epidemiologic research, and also basic science work too. So how do you do it?
I think you're too kind. I think it's a struggle, really. I don't think I have it all figured out. I think, I kind of take it day by day, but I do set goals. There's a lot of things you can do on a weekly kind of schedule basis where you can optimize some areas of your calendar where you will dedicate time to things that are priority. I try to get rid of stuff that is not going to move me into the direction of the goals as much as possible. And while at the same time being putting patient care first, because, that really drives our mission. So surgeon scientist, I think, is an extremely rewarding path, but it's very demanding. So for those of the folks who've had children, will know it's a kind of the same feeling. Having children and raising children is really rewarding, but it's really tiring and exhausting at the same time. Both can be true. I think being a surgeon scientist in many ways is like that. It's extremely rewarding because, you get to really drive the field, change the field. I think that really is my passion. And the days you have defeat, or disappointment in the clinic with the patient, et cetera, and Monty, you may speak to that as well. When you get back to your research program and you see success there, you see hope. I think that really drives the mission of what we do.
So true. It really does kind of come full circle, doesn't it? If you're having a tough day in clinic, see bad outcomes, which inevitably and unfortunately we do in this field, it's great to know that maybe on the nights and weekends when you're either culturing cells or writing a paper, maybe that's actually pushing the field forward, right?
Absolutely. And I think, it kind of sounds cliche, but I think when you really love what you do, then it doesn't seem like work. So, I think a lot of the research things that I do, one of my hobbies, so it's actually, fun to be engaged in that way.
Yeah, well, among the many bodies of research that I like to follow coming out of City of Hope, I think yours is one in particular that I'm excited to see push forward. And I'll speak first to the clinical domain. So I think you've really been known across the country for the role that you play in a surgical technique called PIPAC. I doubt all of our listeners are necessarily familiar with PIPAC, so you could kind of spell that out for us if you don't mind.
Yeah, for sure. So, one of the challenges we have in treating solid tumors is metastatic disease. And one of the sites of metastases that takes a lot of lives, and there's not a lot of good therapies, and there are a lot of reasons why we don't have good therapies for those patients, is peritoneal metastases. So, your abdominal cavity has this inner lining, and any organ in the abdomen, and sometimes organs outside the abdomen, when they metastasize, they will cause peritoneal metastases, which are extremely horrible, miserable metastases because they lead to a lot of symptoms, a lot of suffering. And I think surgical oncologists see this day in and day out. I'm sure, Monty, you've had a lot of patients with that problem too. And really, there are very limited therapies for patients. And so one of the missions early on that I saw was to develop a better strategy to treat peritoneal metastases. So PIPAC is one way to do that. So it is a technique where we give aerosolized therapy, not just chemotherapy. It could be any sort of therapy in the abdomen directly to the tumor. And the beauty of the technique is that, patients can go home the same day. They don't have to stay in the hospital as opposed to conventional surgery. I think there's a lot of promise in the approach. It hasn't been proven effective yet in the way that we want it to be proven effective, for example, in a randomized study. But I think there's a lot of promising signal that is prompting us to advance this further. And so one of the unique things about this strategy is that you get to take tissue samples every time you do the therapy. So you get to study the tumor evolution in response to therapy, which is really exciting for me because you can really study the patient model of disease.
These cases, you're so right about this, those cases of mental caking, of peritoneal carcinomatosis, where the cancer really moves diffusely through the abdomen. those are some of the toughest ones to see, I would say, in the clinics. I mean, these patients are really under extreme duress. So with this PIPAC approach, this positive pressure approach, am I thinking of this too simplistically? Are you just sort of forcing the chemo or the targeted therapy or whatever you're using into tumors just via positive pressure?
Yeah, so there's a couple of claimed benefits of it, and some of them have been validated, others remain to be tested. So I think the biggest advantage of the PIPAC technique is that you can deliver drug homogeneously, drug that could be low volume where you cannot dilute it too much. You can deliver it homogeneously in the peritoneal cavity. Now, in certain preclinical models, folks have demonstrated more penetration depth and, compared to if you just were to do a lavage or irrigate the cavity with the drug. So I think there's potentially advantages of delivering aerosol under pressure, but I think more than that, it's the ability to deliver low volume drug homogeneously throughout the abdominal cavity.
I mean, that makes a lot of sense physically. I mean, in years past, when we just try to have that chemotherapy slosh around, I mean, it's intuitive that it's not going to necessarily hit on all points within the abdomen, just mathematically, geometrically, whatever. So I think this does make a lot of sense. How did this whole premise come about? I mean, what got you thinking about PIPE? I bring this up because, I always think about your chair, Yuman Fong, and he's going to be one of our guests on this podcast. He strikes me as being a real innovator, a cowboy, if you will, in the field of surgery, with always a new thought in mind. And it seems as though you also have taken on that approach.
Yeah, I think the thing that I admire about, Dr. Yuman Fong is that, he is not only a disruptor, but he also encourages disruption. So, I think he, from the very beginning, as I started my faculty position, the idea was to figure out what is the best thing or the next thing in the field. And, one of the technologies at that time that was up and coming was PIPAC. It was being done in Europe, but there's nobody in the US that was really investigating it. And so, went out and learned about PIPAC and figured out what the strategy or what the clinical application here would be and how we can improve on it. Or we saw a lot of potential with the ability to study tissue under treatment longitudinally. And that, I think, because one of the things that we deal with is a limitation to have animal models for peritoneal disease. And to be able to study it within patients, I think that really brought in exciting possibilities to change the face of this disease.
Yeah, I mean, that's just so cool. I got to tell you, Mustafa, I stole a page out of your book, in fact. So I saw that you were putting together this conference that brought together a lot of experts around this domain of intraperitoneal chemotherapy and intraperitoneal techniques in general. When you're sort of operating and adjusting treatments within the abdomen. Now, I did the same sort of in the domain of kidney and bladder and prostate cancer. I love the fact that you're kind of convening folks who have specific expertise in this area. I wonder if you could tell us a little bit about what motivated that.
The diversity of thought and different perspectives are extremely crucial to solve challenging problems. And that was kind of the basis of really making headway. And so we learned that we can't do it alone. So historically, peritoneal oncology has been in the domain of surgeons because, it would typically be diagnosed at the time of surgery, and there's some relationships that patients have already established with the surgeons. And really, it was not a multi-pronged approach, whereas in the clinics, as you're well aware, all of us have to address that problem. And so trying to get everybody to talk together on the same table really brought out a lot of key conceptual advances and breakthroughs, really priority areas, consensus, that I think really has energized that. And we've subsequently, of that group, we've had further meetings. The most recent one was in Lausanne and Lyon. So I think we've gained some momentum. There's a group of folks that are dynamic, thinking progressively about this problem. And I think good things have started to come from that initiative.
Busan and Lyon. That's not shabby. That I got to find a way to, maybe I can carry your bags for you at one of these meetings.
We will invite you next time.
That's great. The other thing I wanted to chat with you about is how we take this to the next level, right? So PIPAC at this point in time is something that I might put into the category of being, a City of Hope special, something that you've really pioneered, something that we're doing for patients here. What's your kind of 5 or 10-year plan for taking PIPAC and really making it more broadly applicable?
So with every technology, there's the ugly side of that is that, folks want to implement it too quickly, especially when they can. And one of the challenges we feel that is going to be, facing PIPAC in the US is, folks will deliver it off-label and it's too premature because we don't have the evidence established. So I think the next step is that we do a randomized clinical trial to prove the efficacy beyond doubt that this adds value to systemic therapy. That is the current standard of care. And without that, I think folks will, we have an example of, for example, HIPAC, which is the heated chemotherapy that we've administered in a number of different types of cancers. For many, we don't have good evidence, and we still struggle to implement that therapy because of the lack of evidence. So now understanding amongst the peritoneal oncology community that we need to develop that standard and not pursue off-label use of a new technology that we haven't really proven to be effective. And so I think that's one way of advancing the use of PIPAC in the US. But I will go beyond that to say that intra-abdominal chemotherapy or regional therapy has a rationale. I think there will be occasions where we will need to give regional therapy if there's a strong rationale for it. It doesn't need to be chemotherapy. I think what this platform allows us to do is to develop the next round of therapy, understand, for example, the samples we take from patients during our clinical trials, undergo extensive scrutiny where we evaluate what kind of cell types are interacting and what pathways, and that will lead to the next generation of therapies that either we give systemically or regionally through PIPAC.
Brilliant. Yeah, I agree with you that we need to have randomized studies in this space. There's no doubt about it, right? Before people are too rogue and implement it into clinical practice. What about vehicles like SWOG and the cooperative groups? I found that to be pretty helpful in terms of, kind of taking rare tumor concepts in my case and taking it to the next level. Have some of those cooperative groups been open-minded about the idea of surgical concepts like this?
That's a great question, Monty. I think there's a little bit of, criticism or apprehension, I should say, about surgical trials, and rightly so, because some of the surgical trials have been difficult to accrue, and we haven't quite figured out what the exact reason for the low accruals have been. But especially the randomized trials, one of the things could be that surgeons have strong biases in favor or against a certain therapy. And it is possible that surgeons may feel that it is hard to randomize patients. And perhaps that is the reason why surgical trials haven't succeeded when they have been, some surgical trials, I should say. I think there's a lot of examples of good surgical trials done through cooperative groups. So there's always apprehension when a surgical trial concept is brought up through the cooperative group. I think in the case of PIPAC, we've had discussions at cooperative groups, and I think the main apprehension is that the technology is too new. The feasibility question comes up, and again, those are valid criticisms. But I think with PIPAC, for example, we feel that there is a sweet window of opportunity when there are a lot of centers doing it already. Then at that point, there's no equipoise. So that is a big challenge for surgical trials, is when everything is familiar and everything is being used off-label, how can you then randomize patients when it's accessible? Because the patients that are randomized to control arm, they're seeking therapy, and in their mind, they want the therapy, and they will go to the center next door to get that therapy, whether it's been proven efficacious or not. So
you're right. That is a huge challenge that perhaps in medical oncology we don't face to the same extent, with our ability to use placebo controls and other strategies to kind of mitigate that imbalance. I could probably go on for hours about the surgical concept of PIPAC, but I want to shift gears and talk about what you do with your pipettes in the lab. So, there's this whole concept of DNA repair pathways that really emerged, I think, in theory when you and I were in training, and now is really, frankly, widely implemented in clinical practice. We have so many targeted therapies that are hitting DNA repair pathways. And your laboratory, I think, has done some really great work in the context of DNA repair as it pertains to pancreatic cancer. I wonder if you could talk to us a little bit about that.
Yeah, absolutely. So pancreatic cancer was one of the reasons I went into surgical oncology. One of my patients with pancreatic cancer who we did this, huge operation on, with arterial and vein resections and everything. We're high-fiving at the end, really happy that we cured the patient. Unfortunately had relapse at their first CT scan after their surgery. And this is not an uncommon scenario. Patients, physicians and a lot of patients and advocates who've seen these stories before know this is a very common phenomenon. Pancreatic cancer is really aggressive disease. And so obviously we need, better ways to tackle pancreatic cancer. So that became, not only piqued my interest in surgical oncology, but also in the basic science research that would then potentially lead to more advances. So things that we study in the lab, I got interested in DNA repair in pancreatic cancer. As pancreatic cancer, as many know, can have a high degree of genome instability. And we looked at the mechanisms of, different DNA repair pathways that may be active in pancreatic cancer that are unique to pancreatic cancer compared to other solid tumors. It turns out there's a specific way cells deal with normal cellular processes. There are two processes that are very key. So DNA replication, where the DNA is being divided, replicated, and transcription, where the message on the DNA is being read. So the two machineries that do these processes have to use the same template DNA. So you can think about it like a train on a railroad track and a person walking on the track. So, the pace of a person at 3 to 7 miles per hour and the speed of the train like at a 370 miles an hour, they correspond to the timescales in biology. So replication and transcription have those kinds of differences in timescales. So if a person is not removed from that DNA template, you can have collisions. In cancer that are driven, cancer cells that are driven by oncogenes, those collisions can happen much more frequently. And the cells have to adapt to those pathways. And my goal was to determine what those pathways are, because essentially those could be cancer selective vulnerabilities. So in doing so, our lab has made a lot of progress where we have discovered a particular pathway called the base excision repair pathway that deals with oxidative damage, actually is a critical pathway to manage these conflicts and could be potentially targeted for therapy. We've identified proteins in the pathway that we are now developing specific drugs and inhibitors for that could potentially be translated to clinic. In the same vein as, you hear about homologous recombination deficient cancers and PARP inhibitors being therapy for them. And so same way, we could have transcription replication conflict targeting therapies that are synthetically lethal with a much broader variety of cancers, not just pancreatic cancer, but maybe more so in pancreatic cancer.
That's amazing. And this is really what I mean when I talk to the audience about you kind of doing it all, right? And you got the clinic, the surgery suite, and then of course you've got, the clinical trials that you're doing, and then this. I love to see this, massive sort of continuous cycle and how all this work really sort of perpetuates itself. On that specific topic, is it as simple for a surgeon scientist, as I believe it is, to actually operate on a patient, get those specimens, and actually transmit them to the lab for study? I mean, is that something that happens in the course of your routine day at work?
I think it's a little bit institution specific. I think City of Hope does a lot of things that are really great, in terms of facilitating that. I think there's a lot of discussion into how a study is set up. Of course, the sample has to get through pathology, where they take the appropriate sample and readings to make sure that the reports are available for clinical decision making. And then, when patients have consented to research use from that, usually we will take the samples to the lab. And it's not uncommon that I find myself taking the sample to pathology once I've concluded the procedure and walk it to my lab, which is across the main hospital, which is very convenient. And And really, I think that is sometimes the most exciting part of the job, is to be able to, get the sample to my lab members, and, having them run special tests on it, and finding something new every day, So that's really exciting. Yeah.
Paint a visual for our audience. So how far away is your operating suite from your laboratory?
It's literally 100 yards away. So we operate on the second floor of the Helford, and about 100 yards right across from the main entrance is the research lab building. Second floor is my lab. So it's really close by, yeah.
That's really cool. See, I wish I could do something like that, although I can barely use a butter knife, so I don't think I should be anywhere near a scalpel, so I'm probably the right place. This last domain of research, so we touched on clinical trials, we touched on the lab-based work that you're doing. That last domain pertains to what I'll call looking back, some of the retrospective work that you've done, characterizing outcomes. And I have actually followed a lot of these papers with a lot of interest. There's a couple of things I like about them. I'm going to say first and foremost, what I think is great is you actually have a lot of your fellows working on these projects, and it's great for them to get podium opportunities and presentation opportunities all around the country for this stuff. What would you say are some of the key findings from some of the retrospective work that you've done?
I think I'm really passionate about the healthcare access piece of it. So, we always want to answer clinical questions through retrospective data. I think a lot of them end up being hypothesis generating. But I think one place where I think retrospective data is really useful is when it impacts policy. When I look back at some of the work we've done in that space is, understanding how insurance actually impacts access to surgical care. And what I mean by that is that somewhere about 2 decades ago, and even before that actually, there was privatized Medicare. So to cut costs in healthcare utilization, managed care plans have really taken off. And we know that this entity called Medicare Advantage, where private insurers are paid by CMS to administer Medicare, has really become more and more popular over the years. And there's good and bad things to managed care. There's checks and balances, which cut costs, which is we know that healthcare utilization and costs have been driven through the roof. And so we really need to cut back on that. But on the other hand, it limits access because there's no set standards, or the standards that have been set may not be adequate for specific kind of care. So we really looked at, our patients who need a pancreatic cancer surgery or lung cancer surgery or any kind of solid tumor surgery that requires inpatient hospitalization. Are they getting those surgeries at the appropriate places they need to be getting at? In surgical oncology, there's a long-standing understanding that practice makes perfect. And so high-volume centers that do it routinely, have the best outcomes, which makes very intuitive sense. But what we learn is that majority of surgeries in California that require high-volume surgery do not happen at high-volume surgery centers. They happen in centers that maybe do 1 or 2 cases a year, and so that is not enough to ensure good outcomes. And the underlying barrier to that is lack of access, which is because insurance may not authorize patients to see physicians, for example, at City of Hope, but also other centers that are really capable of providing the best outcome.
I got to tell you, that's something that I chat with patients about a lot, in the sense that, there's certain aspects of what I do as a medical oncologist that are somewhat transferable. If I prescribe chemotherapy regimen A, it can probably be broadly implemented anywhere, right? But if you've got a specialized surgical procedure, you've got a clinical trial in either one of our hands, right? That's something that you really need to go to a place like City of Hope for, right? And maybe I'll ask you this. As we expand our reach, right, we've got the Duarte hub that used to be headquarters for us, but now, in fact, we're a national organization, right? We've got Chicago and Atlanta and Phoenix. Knowing you, I know this is something that you've thought about already. How do we take this massive expansion that we've had and really utilize it to really harness some of these great sort of research elements that we have here at our institution?
I think you're asking a really, really timely question, because I think that is something that we've had a lot of discussions within the Department of Surgery, actually institution at large, right? So making sure that as we reach more people, the same quality that we are so proud to have here at City of Hope at the main campus, how can we ensure that reaches further? And also the academic flavor of the Duarte campus, which is very unique. The entrepreneurial spirit that lives here is very unique. How do we, kind of recreate that at some of the other sites also? I think from a surgical standpoint, I think a lot of the best outcomes can happen with surgical planning. So there's the technique of surgery, which is really critical. So there's no alternative solution to that unless other than to have skilled surgical hands in the operating room. But then beyond that, there's a lot of surgical planning. Good decision making can happen even before you get to the operating room. I think surgical outcomes are also a function of how you rescue patients if they have complications. And so setting that infrastructure in place, at the sites where we're doing certain operations, and then challenging case conferences. We've implemented things like that where anybody can bring their case across the community sites, and we have a discussion about the best way to approach it. And sometimes that leads to having additional expertise on that case, and sometimes that may trigger an alternative plan of action. So I think that's been extremely valuable. But I think this is a learning process. I don't think we have, and this is why it's working at Safe Hope is so exciting, because I think we get to set the example of leadership in this space. I think this is something that hasn't been done well before, and I think there's a big opportunity here.
That's a much better idea than my idea, which was to go into your lab, to clone you, and to put one of you in Chicago, Atlanta, and Phoenix. I think that's a lot more practical. Yeah, it's interesting. I love chatting with you and Fong again. I'll bring him up again, who's your department chair in surgery. And again, such an outside of the box thinker. And I've chatted with him about remote surgery, you potentially operating on a patient at our Atlanta site from your desktop here. I know I'm oversimplifying this in Los Angeles from some sort of portal. How realistic is that stuff? Is that remote surgery, you think, something that's going to happen in the reasonably near future?
I think so. I think it's on the horizon. I think some of the initial pilot studies are ongoing. It's too soon to say what the use cases will be for that. There's a lot of regulation that needs to mature around that. I think public acceptance is a big piece to it.
Yeah.
I think with autonomous vehicles, I think there has been acceptance of automated technology with AI getting into our lifestyle. I think eventually there will be public acceptance of remote surgery or autonomous surgery in some way. And I think in places there could be some assistance. For example, you have lane changing car assistance. In surgery you may have go no-go zones, which are on the horizon. I think it will make surgery safer in many ways. So I think, like with any new technology, implementation is the key, and checks and balances will be needed, but it's a fine balance where too many checks and balances can make a technology dead on arrival, right? But I do see that there is some implementation in the near future.
Yeah, I love this concept because I think about generalizability of everything that we're doing, and it's so important, right? That our research findings, everything that we're advancing the field with, translates to the global community at large. And it brings me back to the start of our conversation. Growing up in Pakistan, right? For instance, I used to make multiple trips back to India as a kid. You see this abject poverty around you, right? And you think, gosh, there's no way we're ever going to get to a point where we have enough surgeons, medical oncologists to meet the needs of this population. But with things like remote surgery, maybe there's a way that we can put these centers in underserved portions of the world, and certainly we have plenty within the US, and really sort of translate some of these findings to a broader population.
Yeah, I think the with low and middle income countries, I think challenges tend to be very unique. And I've engaged with the surgical oncology group in Pakistan, and I think I've learned so much from them. What they are able to do in resource constrained settings, and the innovation that happens there is truly remarkable. And it's an innovation that is happening without the presence of resources, right? And so just understanding the problems, I think there's a lot of need for collaboration. I think the things that people do wrong is that, sometimes we have our ideas of what may work in a low and middle income country, whereas it is disconnected from the reality because it's not the true ground truth, and so collaborative environment and kind of figuring out what is needed actually can really, pay dividends in that situation.
No, that's brilliant. I'm usually not bewildered when I go onto social media, Twitter, LinkedIn, et cetera, and see what's happening at the institution. But one day I opened up my LinkedIn and I saw that City of Hope had actually gotten a $150 million gift, the Stevenson Prize, which is meant to advance the field of pancreatic cancer research. I mean, this has got to mean big things for the institution, right?
Absolutely. I think, pancreatic cancer obviously has been a cancer that has really struggled to get funding from the national research bodies, and the amount of mortality that we see with pancreatic cancer is not matching up with the funds that we receive. And I think that's changing. There's a lot of advocacy around that, and I think the gift like the Stephenson Prize really sets, charity begets charity, right? And so it sets the tone that really we need to invest more for pancreatic cancer research. There are numerous examples where research investments from philanthropists have led to really breakthroughs and set the stage for progress in the field. So, I am really excited where this will take us, in terms of pancreatic cancer research. As somebody who runs a pancreatic cancer focused lab, I'm really looking forward to the collaborations and the infrastructure changes that this will bring. And I think really it will put City of Hope's pancreatic cancer research programs to be amongst the best.
It really was, hard for me not to think immediately of you and Dr. Fong and, and Dr. Melstrom and the whole gang that's so dedicated and focuses, I think, gosh, what better accelerator of research in this space than this wonderful gift?
Yeah, totally exciting. Yeah, I think we've already had a lot of conversations about what would it mean to think differently and out of the box and really advance not only the understanding of pancreatic cancer, but also potentially therapy.
I'm going to shift gears and ask you a totally random question here. One thing that I've really, been impressed with on this podcast is that every single one of our guests has massive levels of achievement, in the clinics, in the operating room, and research, et cetera. And it just seems at the outset that they have time for nothing but that. But clearly, I know you're an awesome dad, you're a family man. What stuff do you enjoy doing outside of the hospital?
I think right now, I think the hobbies do take a backseat, right? When you have a young family, I think that is really exciting, though. Living through your kids is something that really brings a lot of joy to me. But I do, when I was in medical school, and even before that, I was really into music. So I know Monty, you play guitar too, and so we had a band, and we used to play electric guitar. It's called.
You never told me that.
I've kept that away from you because I know you would invite me to your garage band.
Yeah.
So yeah, but we had a band called Drug of Choice, Doc, and in medical.
Awesome. Drug of Choice. Okay.
So we played 70s classic, Zeppelin, Pink Floyd, and the true classic rock, if you will.
Oh my gosh. Okay, now you're not escaping an invitation. Within the next couple of weeks, you're going to be in my garage. I guarantee it.
Sure.
That is so cool. See, I learned so much about folks just through, these simple questions that, the other thing that I've pitched to a lot of folks on this podcast is, we've titled this podcast On the Edge of Breakthrough. So what does the edge of breakthrough mean to you, perhaps as it pertains to City of Hope?
So I think we need cures, we need better therapies, right? And so, again, it sounds cliche that, or maybe it may sound naive, but I think really, if we are not in the business of curing cancer, we're really not doing our job properly, right? And so as a researcher, I do think a lot about the basic discovery, but I do, as a surgeon scientist, cannot escape the true reality that I see every day. There are patients who will die because of their disease, and we run out of therapies, and we don't have curative treatment. One of the cancers I treat, is appendix cancer, for example. Many people not even heard of it. It's a rare cancer, but not at City of Hope. In the clinics, I see a lot of it, and there are 0 FDA-approved therapies for appendix cancer. So things like that really, I think, need to change. And so for me, cutting edge is if we have a therapy for challenging cancers that actually makes people live longer with good quality of life, and even helps them get rid of disease when there is no hope for them, when it's stage 4 cancer. I think that would be the best thing that we could shoot for.
I have to say that City of Hope to me has always represented a place that really has maintained this focus on the rarest of rare cancer types. So I'm glad you actually brought up appendiceal cancers because, again, that's something that's really richly needed. We've got to have more trials and research in that space. I feel the same way about the rare kidney cancers that I treat. And without, sort of the ultrastructure of this institution, I think that research could be incredibly, incredibly challenging. Gosh, Mustafa, I learned so much today. I learned about PIPAC. I learned about base excision repair. But the one thing I'm going to take home with me is that you play Led Zeppelin on your guitar, and you're going to join my band, whether you like it or not, okay?
I will take you up on that offer.
Well, thanks so much for joining us today. We've got to have you back again.
Thank you so much for having me.
This podcast was produced in partnership with Amaze Media Labs.